As we all know, that SARS-CoV-2 has a panel of symptomatic and asymptomatic range of signs. And the case fatality, if we see here for the latest numbers of the confirmed laboratory infections and deaths, so the case fatality is approaching today at about 0.9%, thanks to the use of the vaccine, which reduce it extremely. And then we will talk about the long COVID. Long COVID, after the recovery from the acute COVID-19, people may feel unwell for months, and this could be 1 to 3 months, and can't be explained by alternative diagnosis. Then they can be categorized as long COVID. So, if we return here for the number, then we found about more than 776 million laboratory confirmed cases, and you expect about 10-fold more for silent infections that didn't went to the laboratory confirmations. So, and then the literature here, they mention that about 10 to 30% of non-hospitalized patients are suffering from long COVID. This is the latest percentage, and if we go to the severe diseases, then the ratio is extremely increased. So for the best situations, we have at least 77 million people who have long COVID worldwide. So the signs detected with long COVID, there are more than 200 signs related to the variety of organs and systems as you see here. They found that the long COVID is associated with some risk factors, including the female sex, age above 30, smoking, obesity, comorbidity, and social and economical stressors. And this is, from my point of view, one of the most important issues, the emotional and the social stressors. We all are under stress due to the panic from COVID-19. So everything is explained by COVID-19. And another thing is the autoimmunity. So this also one of the risk factors for developing COVID-19. Today, I will try to focus on the neurological and psychological signs of long COVID-19, which is collectively called brain fog. And then we try to demonstrate the possible causes of long COVID. We have hypothetical theories for different potential causes of the long COVID, including neurotropic tendency of the SARS-CoV, the persistence of SARS-CoV, neuroinflammation, autoimmunity, and reactivation of the latent viruses. So, again, we should remember that we are talking about 77 million people, so we should search about a mechanism that could explain such widespread of such greatest number of people with long COVID. So for the neurotropic tendency, it is possible. However, in fact, it's detected only in very rare cases. Makes such a possibility not be the major inducer for such and to explain the long COVID. Because yes, there is an evidence for people who suffer from neurological affections, but it is a rare situation. And yes, there is experimental infections, as explained by Mario and Udini, that there is experimental infections for mice that confirm that neurotropic tendency for strains. For this study, they found for Omicron and Wuhan strain, both are able to have neurotropic tendency. And then the second strategy could be the persistence of SARS-CoV-2 inside the body. And in some rare cases, patients mainly in immunocompromised patients, they showed evidence for the persistence for months, and in one study, it reaches about 230 days. However, little evidence in that study confirmed that there is either inflammatory changes or something like direct viral cytopathology outside the respiratory tract, except in cases with multiple organ failure. Because as long as the patient suffers from multiple organ failures, everything are affected. So in that study, they found that 27 patients still ill, but recovered and converted negative for SARS-CoV-2, and then the clinical condition progressively declined. And upon PM, revealed interstitial pneumonia in 24 out of 27 people. 22 of them were positive for immunohistochemistry of the lung, and only 9 patients of whom showed weak positive RT-PCR. In another study, they found increased active microglia in the autopsies of patients who were SARS-CoV-2 positive at the time of death without COVID-19 symptoms. Another studies found that the subgenomic RNA was detected in adult patients who died after 42 to 57 days of the disease. So we have, as we discussed with Lewis in the first talk today, that the persistence of the virus, it happens, okay, and it is recorded not only in the SARS-CoV-2, but also in other viruses or other human viruses that common. OC43, it is confirmed that it has a persistent profile, and also for the animal viruses like transmissible gastroenteritis viruses in pigs, it also induced persistence. But in a recent study, they found that the distributions of the subgenomic RNA in different tissues. But if you look at the CNS, you will find insignificant this correlation, insignificant p-value here. So it distributed in different tissue, most of the tissue of the body, but when they are looked for the CNS, it was slight bit insignificant value in comparison to that study. Okay. For the third mechanism is the neuroinflammations, which they made in one study. They made experimental infection of SARS-CoV-2 in transgenic mice to express human ACE2 in lung only, and then they found mild inflammation and histopathology in the lung, where the human ACE2 is expressed, and also interleukins 5, 6, 18, and interferon gamma in the serum, as well as CSF. So, in addition, they found CLL11 in CSF and serum, active microglia in the white matter up to 7 weeks post-infection, and reduced neoplastic activity, which lead to impaired hippocampal neurogenesis in mice with mild COVID, which will lead to memory impairment and cognitive and emotional dysfunction. However, CCL11, they are related to as indicator for the neuroinflammation in that animals. But looking in a wider scope, that we find that CCL11 was also found in different viruses, including influenza viruses, dengue fever viruses, West Nile viruses, latent TB infections, Zika viruses, vesicular stomatitis viruses in mice. So probably it could play a role, but the SARS-CoV is not the only inducer for CCL11. Also, experimental infection for influenza viruses induce cognitive impairment 14 to 20 weeks after the infection, and hippocampal morphology changes. CCL11 is highly expressed in lung of the neonatal mice infected with influenza A virus. So we have different incriminators for CCL11, so SARS-CoV is not alone. So neuroinflammation is caused by non-neurotropic viruses for human H3N2, but not H1N1, and also neurotropic influenza viruses like H7N7. For the neuroinflammation, the microglia is incriminated all the time. For the microglia is differentiated into M1 and M2. M1 is the benign, is the good guy, and the M2 is the bad guy. Okay, so it is incriminated in case of the neuroinflammation, that it makes major changes that lead to the inflammation in the brain and the neurological affection and psychological affections. For the fourth hypothesis, that reactivation of the other viral infections. As long as there is an infection, there is a stress, and then the king of the latency appear, which is herpes. Okay, the herpes viruses, including ABV, VSV, HSV 1, 2, HSV 6, and HHV 7 were detected in patients with long COVID. Human herpes virus 6 and P, more frequently P infection, can induce neuroinflammation since its presence frequently in normal tissues. ABV causes also neuroinflammations. ABV infections was detected in 93% of MS and 78% of control pain. So it finds all the time, ABV is found all the time. It has very high prevalences. So it is found in association with certain affections like MS and also Parkinsonism and many other affections. So, oops. I guess that the reactivations of these viruses may play a major radical role for the neurological affections associated with the long COVID. For the autoimmunity, actually there is no significant correlations between the people who have autoimmune disease and the long COVID. However, there is evidence that and finding that the EBV is the main incriminators for the long COVID, and the EBV is an inducer for directly or indirectly for many autoimmune diseases. So SARS-CoV, other virus reactivation, and then autoimmunity happens. So the autoimmunity could, from this point of view, could play a role for the long COVID affections. So the most common finding in the long COVID patient was anti-ABV immunoglobulins, as well as high CD4 positive cells, in addition to CXCR3, which is the main receptor for CCL11, CD8 positive cells. Also high cytokines, and here high galactin-1, and in addition to, it was associated with low cortisol level. But combination of more than one factors is most probably incriminated in the long COVID. Again, SARS-CoV is not the only cause associated with the post-acute syndromes. So if we look at the post-acute syndromes, we all concentrate nowadays and since 2 to 3 years on SARS-CoV-2, but didn't look for others in the dark. In addition to, we are not alone, so we don't actually, the pathogens, the viruses are not the inducers for psychological and neurological conditions. There's on in the other side, hormonal disturbances, panic, anxiety, and then stresses that all play a role in inducing long COVID. So, and here is also the list again for the viruses that could be associated with post-acute long-term diseases for the treatment of the long COVID. So if we say that it induces about more than 200 signs, then one treatment will not help. So for the treatment, it could be symptomatic to treat the signs mainly, and then supportive treatment, and then rehabilitative treatment with self-monitoring. The proposed drugs and ongoing clinical trials are trying to find solutions for and treatment protocol to handle the patient with long COVID, including leukotriene antagonist and also nicotinamide ribosides, hyperbaric oxygen therapy, especially for patients with fatigue, probiotic therapy to change the microbiome of the patient with long COVID, because the long COVID patient, in most of the cases, they got a huge amount of antibiotics, and the microbiome of the intestine and the respiratory tract has been changed, then it could be also play a role in the inductions of long COVID. So the probiotic therapy is one on the ongoing trials as a treatment trials for the COVID-19 long COVID. Metformin, which is a commercial name, is glucophage, the main first-line medications for the treatment of type 2 diabetes. And recently, there is a preprint announced that it is, oh, sorry, not this one. Okay. Also, there is CCR3 antagonist. There is also a target for neuropathic pain therapy, which would lead to downregulation of CCL11 and CCL7, which is good for long COVID-19. And could be, I think there is many investigations that the drug as a potential drug for the long COVID. Metformin, which is the glucophage, which is the main treatment for type 2 diabetes. A recent study found a new hope that it possesses about 42 active decrease in the incidence of long COVID signs in the secondary outcome in randomized trial 3. But actually, this is not the end of the story. The FDA raised a concern about this finding, since the analysis showed no benefits for any of the 3 investigative agents, including metformin, ivermectin, and fluvoxamine, in preventing the primary endpoint. So the sun set. One of the most important pillars that we could help in long COVID is psychological and social determinant of the public health that have a great impact on the outcome of the disease. And this is one of the most important things, the supportive treatment with the patient of COVID. For my opinion, will play a major role in the treatment of the long COVID. Conclusion, long COVID needs attention, and many overlapping causes could be inducers of the long COVID syndrome in addition to SARS-CoV-2. Many pathogens can induce similar conditions. No current treatment for long COVID. However, it could be divided into symptomatic, supportive, rehabilitative treatment with self-monitoring. Just highlight for some of our COVID research, we have investigating the manifestation and duration of the long COVID is positively correlated with the severity of the disease. We found cognitive dysfunction, depression, sleep disorders, as well as loss of taste, smell were reported in more than 6 months in up to 7.7% of the subject. We also found changes in the menstrual cycles for more than 6 months were reported in 6.4% of the Saudi female. We have conducted different multidisciplinary from 3-dimensional point of view, from antiviral, viral evaluations, clinical funding, and public health. And this is our clinical research publications that have already done with clinical virology. And then We have conducted virus evolutions with some of our collaborators in India too. And post-vaccinal and post-infection long-term studies. Thank you for attendance.
Thank you very much.